The surgeon looks down at the foot and knows what comes next. The wound has been open for months, refusing every treatment. It started small, a blister, a scrape, the kind of injury that should have healed in a week. But diabetes doesn't let wounds follow the usual script. Blood flow weakens, nerves go silent. What should have closed instead spread, deeper and wider, until the tissue began to die. The smell arrives before you enter the room. The edges of the wound have turned black. Gangrene has set in, slow and patient, eating away at flesh while the infection ignores every antibiotic thrown at it. Broad-spectrum coverage, targeted therapy, combinations designed to overwhelm resistance, none of it worked. The bacteria had seen it all before. The wound didn't improve, it didn't stabilize, it simply refused to heal. So the surgeon delivers the line everyone expected, but no one wanted to hear. The next step is amputation. Remove the foot before the infection climbs higher. The conversation is brief. The surgery is scheduled. The form is signed. Then someone mentions another option. Not a new drug, not a laser or a graft. The option is maggots, live ones, placed directly into the wound. The smell hangs in the air like something out of place, something that doesn't belong in a sterile hospital room. It sounds medieval, it sounds desperate, but it's not. It's an approved medical procedure, cleared by the FDA, used in hospitals across the world. It's medicine. It just doesn't look like it. The formal name is Maggot Debridement therapy, and the precision behind it becomes clear the moment you understand what debridement actually means. It's the removal of dead tissue from a wound, the cleaning away of everything that's no longer alive but hasn't yet fallen away on its own. Surgeons do it with scalpels, nurses do it with forceps and gauze. Chemicals can do it if the wound allows. But all of these methods share the same fundamental problem. They're blind. A blade doesn't know where dead tissue ends and living tissue begins. A chemical doesn't distinguish between what's rotting and what's healing. They remove what they're told to remove, and sometimes they take more than intended. Maggots don't have that problem. The species used isn't random. It's almost always Lucilia sericata, the green bottlefly, chosen not because it's convenient, but because its larvae have evolved to do exactly one thing with extraordinary efficiency. They consume dead tissue. Only dead tissue. They ignore everything else. It's not learned behavior. It's not training. It's biology, refined across millions of years of feeding on wounds and carcasses in the wild, turned into a medical tool simply by recognizing what was already there. The process itself is deliberate and controlled. These aren't wild maggots pulled from some neglected corner. They're laboratory-raised, sterile from the moment they hatch, grown in environments cleaner than most operating rooms. They're measured, counted, placed into the wound in specific numbers based on the size and depth of the infection. Some are enclosed in small mesh bags that look like tea sachets, keeping them contained while still allowing them to do their work. Others are left free to move across the wound bed, their motion part of the therapy itself. The goal is simple: clean the wound without destroying what's still capable of healing. Remove the rot, leave the life. It's biological cleaning, as precise as any surgical instrument and far less destructive than most. The difference between a scalpel and a maggot comes down to information. A surgeon, no matter how skilled, is working with limited data. The tissue looks dead, feels dead, but the line between necrotic and viable isn't always visible to the human eye. Under the harsh lights of an operating room, everything can look questionable. The blade moves based on judgment, on experience, on the best guess of where healthy tissue begins. Sometimes that guess is right, sometimes it's not. Sometimes the cut goes too deep, removing muscle or fascia that could have survived, that could have contributed to healing. Sometimes it doesn't go deep enough, leaving behind pockets of decay that will sabotage everything that follows. The surgeon can't feel the difference. The instruments can't sense it. They cut where they're directed, and the wound either recovers or it doesn't. A maggot doesn't see the wound. It has no eyes to distinguish color, no sense of what tissue looks like from the outside. But it doesn't need vision. It navigates by chemistry, by the molecular signature of decay. Dead tissue releases compounds that living tissue doesn't. Proteins breaking down, cells rupturing, the specific scent of decomposition at a level far below what any human nose could detect. The maggot's receptors lock on to those signals with absolute certainty. It moves toward what's dead and begins to feed, secreting enzymes that liquefy necrotic tissue, breaking it down into a form it can absorb. It consumes the rot bit by bit until there's nothing left, and then it stops. Not because it's full, not because it's finished the job, but because the chemical signals have disappeared. The living tissue around it produces none of the markers that trigger feeding. The maggot simply ignores it, as if it doesn't exist. It will crawl over healthy muscle, across viable skin, searching for more decay, but it won't touch what's alive. It can't. The biology won't allow it. That precision, that chemical certainty, is something no scalpel has ever possessed. What happens inside a single maggot is less like simple feeding and more like a coordinated chemical assault on everything that doesn't belong in a healing wound. The larva doesn't have teeth. It can't bite or chew or tear tissue apart the way larger scavengers do. Instead, it liquefies its food before consuming it, turning solid matter into something it can absorb. The process begins the moment the maggot settles onto necrotic tissue. Glands along its body start secreting enzymes, powerful proteolytic compounds that target the structural proteins holding dead cells together. Collagen breaks down, fibrin dissolves. The tissue that was rigid and black and foul-smelling starts to soften, then to liquefy, transforming from solid flesh into a thin, nutrient-rich fluid. The maggot doesn't have to work for its meal. It simply releases the enzymes and waits while the chemistry does what millions of years of evolution designed it to do. Then it feeds, drawing the liquefied tissue into its body, leaving behind a surface that's cleaner than it was minutes before. The wound is no longer a graveyard. It's being processed, sterilized at a microbial level, converted from a site of decay into something that might actually support new growth. And the maggot isn't finished. The enzymes are only the first part of what it brings to the wound. As it feeds and moves and secretes, it's also releasing a cocktail of antimicrobial compounds, substances that don't just clean tissue, but actively kill the bacteria that have colonized the infection. Allantoin is one of them, a molecule that promotes cell growth and suppresses inflammation, turning the wound environment from hostile to hospitable. Ammonia is another, raising the pH of the area, creating conditions where many bacteria simply can't survive. The wound bed, which had been acidic and inflamed and teeming with resistant organisms, begins to shift toward alkalinity. The bacteria that thrived in the old environment suddenly find themselves struggling. This matters more than it sounds. The infections in these chronic wounds aren't ordinary. They're not the kind that respond to a single course of antibiotics and disappear. These are MRSA, methicillin-resistant Staphylococcus aureus, the strains that laugh at penicillin and shrug off vancomycin. These are Pseudomonas species that have adapted to survive in the harshest hospital environments, that have seen every drug in the antimicrobial arsenal and developed mechanisms to neutralize them. They form biofilms, protective layers that shield them from immune cells and medications alike, turning the wound into a fortress that standard treatments can't breach. But the compounds secreted by maggots don't work like antibiotics. They're not targeting specific bacterial enzymes or disrupting cell wall synthesis in ways that bacteria can evolve around. They're changing the entire environment, making it chemically inhospitable, forcing the bacteria to either adapt to conditions they've never encountered or die. And because these substances come from a living organism that's been locked in an evolutionary arms race with bacteria for eons, resistance doesn't develop. The bacteria can't adapt fast enough. They die, and the maggot continues feeding, and the wound gets cleaner with every hour. But even this isn't the full picture. The maggots aren't just removing dead tissue and killing bacteria. They're actively promoting healing in ways that weren't understood until researchers started looking closer at what happens in wounds during maggot therapy. The movement of the larvae across the wound bed isn't random. As they crawl and feed, they're physically stimulating the tissue beneath them, a kind of continuous micromassage that affects blood flow at a capillary level. Vessels that had been constricted, starved of oxygen, begin to dilate. Blood flow increases, bringing with it oxygen and nutrients and immune cells that had been absent. The tissue starts to wake up. The pH shift caused by ammonia and other secretions does more than kill bacteria. It triggers signaling pathways in the cells that remain alive. Stem cells in the local tissue, dormant or sluggish, begin to activate. They start dividing, differentiating, contributing to the formation of new granulation tissue, the pink, healthy layer that eventually fills a healing wound. The inflammatory response, which had been stuck in a chronic, destructive loop, begins to resolve. The wound isn't just being cleaned, it's being reset, returned to a state where the body's own repair mechanisms can finally take over. This is what separates maggot therapy from every other form of debridement. A scalpel removes tissue, chemicals dissolve it, but neither of them changes the fundamental biology of the wound bed. Neither of them kills resistant bacteria without creating new resistance. Neither of them stimulates healing while they clean. The maggot does all of it simultaneously, not because it's trying to heal the wound, it has no concept of medicine or therapy, but because its survival depends on creating an environment where it can thrive, and that environment happens to be exactly what a chronic wound needs to recover. The wound transforms from a site of death into a site of potential, and the maggot, in consuming what's dead, gives what's alive a chance to continue.
The question patients ask most often, once they've agreed to the procedure, once they've pushed past the initial revulsion and signed the consent forms, is what it will feel like. They expect pain. They expect something visceral and unbearable, the sensation of being consumed from the inside, of tiny mandibles tearing into flesh. That's what the mind conjures when you tell someone that live larvae will be placed into their open wound. The imagination goes to dark places, to medieval torture, to scenarios where the body is being eaten alive. But the reality is nothing like that. There's no pain, not in the way most people understand pain. The most common sensation patients report is tickling, not the playful kind, not the sort that makes you laugh, but a persistent, gentle tickling that comes from movement across the surface of the wound. The maggots are small, soft-bodied, and their motion is constant but light. They don't burrow, they don't bite, they crawl slowly over the tissue, feeding as they go, and that motion translates to the nerve endings that are still functional as something unfamiliar but not threatening. Some describe it as tingling, like the pins and needles feeling when circulation returns to a limb that's been compressed too long. Others say it feels like bubbles, like carbonation against the skin, a fizzing sensation that's more strange than uncomfortable. A few patients report feeling almost nothing at all, especially if the wound is deep or if diabetic neuropathy has already damaged the nerves in the area. The maggots work in silence, doing their job while the patient reads or watches television or sleeps, and the only reminder that anything is happening is the occasional flutter of movement beneath the bandage. But there's something else patients mention, something harder to quantify. They say the wound feels alive again, not in a frightening way, but in a way that suggests activity, process, something happening where before there had only been stagnation. Chronic wounds have a quality of stillness to them. They don't heal, don't change, don't respond. They just exist, day after day, a static problem that refuses to improve. The presence of the maggots breaks that stillness. The wound becomes a site of action, of transformation, and patients can sense it even if they can't see it. Some describe it as a kind of relief, a feeling that something is finally being done, that the tissue isn't just sitting there rotting anymore. The psychological shift is subtle but real. The wound is no longer a dead thing attached to their body. It's being addressed, cleaned, prepared to heal. The horror, when it exists, is never physical. It's entirely in the mind. It's the idea of maggots, the cultural weight of what they represent: decay, filth, neglect. The things people associate with maggots aren't medical. They're visceral and primitive, tied to images of roadkill and garbage bins and bodies left too long in the heat. To put that association onto your own body, to willingly allow creatures linked to death and rot to inhabit your flesh, requires a psychological leap that some patients simply can't make. They'd rather lose the limb. They'd rather face surgery, anesthesia, the permanent loss of a foot or a leg than endure the mental image of larvae feeding on their wound. The fear isn't rational, but fear rarely is. It's emotional, instinctive, and no amount of scientific explanation makes it easier. Doctors can show them the data, the success rates, the photographs of wounds that closed after maggot therapy when nothing else worked. It doesn't matter. The brain rejects the idea before reason has a chance to intervene. And so some patients choose amputation, not because the maggots failed, but because they couldn't bring themselves to try.
The pattern was noticed long before anyone understood it. Battlefields have always been laboratories of trauma, places where the human body is broken in ways civilian life rarely produces, and where doctors work under conditions that strip medicine down to its most desperate improvisations. During the Napoleonic Wars, a French surgeon named Baron Dominique Larrey spent years moving between field hospitals, treating soldiers whose wounds were catastrophic and whose chances of survival were slim. He had no antibiotics, no sterile technique as we'd recognize it today, no real understanding of infection beyond the vague notion that some wounds festered and others didn't. What he did have was time to observe, and what he observed didn't make sense at first. Soldiers brought in from the field often arrived with their wounds already infested. Maggots, drawn to blood and torn flesh, had found their way into injuries within hours of the battle ending. The sight was repulsive, the smell was worse. Larrey's instinct, like that of any physician, was to clean the wounds immediately, to remove the larvae along with the dirt and debris, to restore some semblance of order to the mangled tissue. But he noticed something strange. The soldiers whose wounds were filled with maggots survived at higher rates than those whose injuries had remained clean. The infested wounds, despite looking worse, despite the horror of watching live larvae move through exposed muscle, healed faster. The tissue around them stayed pink and viable. Infection, when it came, was less severe. The soldiers complained less of pain. Meanwhile, the wounds that looked clean, that had been carefully bandaged and kept free of contamination, turned foul within days. The tissue blackened, fever set in, gangrene spread, and men died not from the initial injury, but from what came after. Larrey didn't understand why. Germ theory wouldn't exist for another half-century. The idea that bacteria caused infection, that invisible organisms were responsible for the rot and fever that killed more soldiers than bullets ever did, hadn't yet entered medical thinking. All Larrey had was the pattern. Maggots meant survival. Clean wounds meant death. It was backwards, counterintuitive, impossible to reconcile with everything medicine believed about cleanliness and contamination. But the pattern held, battle after battle, wound after wound. Nature, it seemed, knew something medicine didn't. The observation surfaced again a century later under even worse conditions.
The First World War produced injuries on a scale that overwhelmed every medical system involved. Trenches filled with mud and filth. Shrapnel tore through flesh in ways designed to maximize damage, and the sheer number of wounded meant that field hospitals operated in states of constant crisis. Supplies ran low. Antibiotics didn't exist yet. Penicillin wouldn't be discovered until 1928, and it wouldn't see widespread use until the next war. Sterilization equipment was scarce. Doctors worked in tents with inadequate lighting, inadequate instruments, inadequate everything. And the wounds kept coming, day after day, infected almost from the moment they were inflicted. Maggots were everywhere, in the trenches, in the makeshift hospitals, in the bandages of soldiers who had lain in no man's land for hours or days before being retrieved. The larvae didn't wait for permission. They colonized wounds as soon as conditions allowed, and doctors, stretched beyond capacity, sometimes didn't have time to clean them out immediately. So the maggots stayed, and the doctors watched, and the same pattern Larrey had noticed 100 years earlier revealed itself again. The soldiers with maggot-infested wounds fared better. The tissue remained healthier. The infections were less aggressive. Some wounds that should have required amputation instead began to granulate, to show signs of healing, even as the larvae continued their work. Some doctors took note. A few even began experimenting, deliberately introducing maggots into wounds to see if the effect could be replicated under controlled conditions. The results were promising, sometimes remarkable. But the moment penicillin arrived, the moment medicine finally had a tool that could kill bacteria reliably and predictably, the interest in maggots evaporated almost overnight. Why bother with something so primitive, so distasteful, when a simple injection could achieve the same result? Antibiotics were clean, they were modern, they were easy to administer, easy to explain, easy to accept. Maggots belonged to the past, to the desperate measures of wars fought without proper medicine. The observations were filed away, mentioned briefly in medical texts as historical curiosities, and then largely forgotten. Penicillin had arrived, and with it, the assumption that the problem of wound infection had been solved for good.
The arrival of antibiotics changed everything, or at least it seemed that way. Penicillin, sulfa drugs, streptomycin, each new discovery pushed the boundaries of what medicine could treat. Infections that had once meant certain death became inconveniences. Soldiers wounded in the Second World War survived injuries that would have killed their fathers in the trenches a generation earlier. Bacterial pneumonia stopped being a death sentence. Surgical sites stopped festering. The entire relationship between humanity and bacteria shifted in the span of a decade. Medicine had found its weapon, and the weapon worked with a speed and reliability that felt almost miraculous. Doctors no longer had to improvise with larvae and folk remedies. They had chemistry, pharmacology, science that could be measured and reproduced. The age of modern medicine had arrived, and with it came the assumption that bacterial infections were a solved problem. Maggot therapy disappeared not because it had been proven ineffective, but because it was no longer necessary. Why would anyone choose something so primitive, so unpleasant, when a simple pill or injection could accomplish the same goal? The procedure belonged to a darker era, to the time before antibiotics, when doctors had to make do with whatever nature provided. Medical schools stopped teaching it. Textbooks relegated it to footnotes. The few doctors who remembered using maggots during the wars retired, and the knowledge went with them. For decades, the medical community operated under the belief that the problem of wound infection had been permanently solved. Antibiotics were the answer. They would always be the answer. But bacteria don't stay defeated. They adapt, evolve, find ways to survive in environments designed to kill them. The first signs of resistance appeared early, almost as soon as penicillin entered widespread use. Strains of Staphylococcus aureus that could survive penicillin exposure were identified within a few years. Doctors switched to methicillin,
a more powerful alternative. Then, in 1961, methicillin-resistant Staphylococcus aureus appeared in a British hospital. MRSA had arrived, and with it the realization that bacteria could outpace medicine's ability to develop new drugs. The problem accelerated over the following decades. Overuse of antibiotics in hospitals, in agriculture, in any situation where bacteria were exposed to sublethal doses, created evolutionary pressure that favored resistance. Genes that allowed bacteria to neutralize antibiotics spread through microbial populations faster than new drugs could be developed. The pharmaceutical industry began to retreat from antibiotic research. The profit margins weren't there. The development timelines were too long. And so the pipeline of new drugs slowed to a trickle, just as the need for them became desperate. By the turn of the century, the situation had become dire. Hospital wards filled with patients whose infections wouldn't respond to treatment. Chronic wounds that should have healed refused to close, colonized by bacteria that had learned to resist every available drug. Diabetic foot ulcers, pressure sores, surgical site infections, all of them became potential disasters, not because the initial injury was severe, but because the bacteria that moved in afterward were untouchable. Doctors cycled through antibiotics, trying different combinations, higher doses, last resort medications that came with severe side effects. Sometimes it worked, often it didn't. The wounds festered, spread, turned necrotic. Amputation, which had seemed like a relic of pre-antibiotic medicine, returned as the standard intervention for infections that couldn't be controlled. Limbs were removed not because they couldn't be saved in theory, but because medicine had run out of options. The irony wasn't lost on the older physicians, the ones who had trained in an era when penicillin was still considered a wonder drug. They had watched antibiotics solve problems their predecessors couldn't, had seen infections disappear with a speed that seemed like magic. Now they were watching those same infections return, stronger and more resistant than before, and the tools that had defined modern medicine for half a century were failing. The assumptions that had held for decades, that bacteria could always be controlled, that resistance was manageable, that new drugs would always appear when needed, all of them crumbled in the face of reality. Medicine had built its entire approach to wound care around the idea that antibiotics would always work. When that foundation collapsed, there was nothing to replace it. Except there was. The solution had existed all along, discarded and forgotten, dismissed as primitive and unnecessary. Maggot therapy hadn't disappeared because it failed. It had disappeared because it wasn't needed, or so everyone thought. Now, with antibiotic resistance rising and amputation rates climbing, doctors began to look backward, digging through old literature, finding references to treatments that had worked before the antibiotic era. The studies from the 1930s and 1940s were still there, buried in archives, showing success rates that looked improbable until you remembered that the bacteria back then hadn't yet developed resistance. The observations from battlefield surgeons, the anecdotal reports of wounds healing when maggots were present, all of it resurfaced as medicine faced the uncomfortable truth that it had abandoned something that worked. The return wasn't immediate. There was resistance, both institutional and cultural. Maggot therapy sounded like quackery, like a step backward into pre-scientific medicine. But the data, when researchers started running modern trials, was undeniable. Wounds that wouldn't respond to antibiotics responded to maggots. Tissue that refused to heal began to granulate. Amputations that seemed inevitable were avoided. The larvae did what no drug could, cleaned the wound, killed resistant bacteria, promoted healing, all without creating new resistance. Medicine, humbled by its own failures, had no choice but to reconsider what it had left behind. The maggots came back, not as a curiosity or a last resort, but as a legitimate medical intervention. The past had become the future, and the thing that once seemed too primitive to consider was now the cutting edge of wound care. The turning point came in 2004, when the United States Food and Drug Administration made a decision that would have seemed absurd just a generation earlier. After reviewing the evidence, after examining the clinical trials and the mounting success rates, the FDA granted approval for medical maggots, not as a drug, not as a biological agent, as a medical device. The classification was deliberate, carefully chosen to reflect what the larvae actually do. They're a tool, no different in principle from a scalpel or a laser, something applied to tissue to achieve a specific therapeutic outcome. The regulatory language was dry and technical, but the implications were profound. A living organism, something that had spent a century associated with decay and neglect, was now officially recognized as legitimate medical equipment. The approval didn't just validate the therapy, it transformed how maggots could be produced and distributed. Before 2004, the few practitioners who still used maggot therapy had to source their larvae through informal channels, growing them in small batches, working in a regulatory gray area where the treatment existed but wasn't officially sanctioned. Now, with FDA clearance, the production could become industrial, standardized, subject to the same rigorous quality controls as any other medical device. Companies emerged specifically to breed medical-grade maggots, operating out of facilities that looked nothing like what you'd imagine. These weren't barns or outdoor breeding sites. They were laboratories, clean and climate-controlled, where every stage of the fly's life cycle was monitored and documented. The process begins with adult Lucilia sericata flies, kept in contained environments and fed carefully controlled diets. When they lay eggs, those eggs are collected under sterile conditions, isolated from any potential contamination. The larvae that hatch have never been exposed to bacteria, never crawled across anything that could introduce pathogens into their systems. They're as clean as anything that comes out of a pharmaceutical production line, cleaner than some. Each batch is tested, verified to be free of disease, free of unwanted microorganisms, certified safe for medical use. The oversight is strict. The FDA requires documentation at every step, from the breeding of the parent flies to the packaging of the final product. These aren't wild maggots pulled from nature and dropped into wounds. They're manufactured in the most precise sense of the word. The packaging itself reflects how far the therapy has come from its battlefield origins. The larvae are counted out in specific numbers, then placed into small bags made of fine mesh, woven tight enough to contain the maggots, but loose enough to allow their secretions to pass through into the wound. The bags look remarkably like tea sachets, small and unassuming, nothing that would provoke alarm if you saw one sitting on a medical tray. Some formulations leave the larvae loose, allowing them to move freely across the wound bed, but the bagged version exists specifically for patients who can't handle the idea of direct contact. The mesh keeps the maggots contained, out of sight, reducing the psychological burden while still allowing them to do their work. The patient knows they're there, understands what's happening, but doesn't have to see the larvae crawling across their flesh. The bandage goes on, the treatment begins, and from the outside it looks like any other wound dressing. The irony runs deep. Medicine spent a century recoiling from maggot therapy, dismissing it as barbaric, relegating it to the past, insisting that modern science had moved beyond such crude interventions. Doctors who might have used it kept quiet, afraid of ridicule, afraid of being seen as backwards. The therapy survived only in the margins, practiced by a handful of clinicians who didn't care what their colleagues thought, who cared only about results. And now, after antibiotic resistance forced medicine to confront its own limitations, after chronic wounds piled up in numbers that couldn't be ignored, the same establishment that rejected maggots for generations was giving them official approval. The FDA wasn't endorsing some fringe treatment. It was acknowledging that something dismissed as disgusting and primitive worked better than the alternatives, that the larvae accomplished what drugs and surgery often couldn't. The acceptance didn't come with fanfare. There were no press conferences celebrating the return of maggot therapy, no public declarations that medicine had been wrong to abandon it. The approval was quiet, administrative, buried in regulatory documents that most people would never read. But within the medical community, among wound care specialists and infectious disease physicians, the significance was clear. A door had opened. Hospitals could now use maggot therapy without fear of liability. Insurance companies could reimburse for it. Doctors could prescribe it openly without having to justify why they were resorting to something so unconventional. The treatment that had existed in the shadows for decades moved into the light, not because attitudes had suddenly changed, but because the evidence left no room for continued denial. Medicine had accepted the idea, not because it wanted to, but because it had no choice. And sometimes that's how progress happens, not through revelation, but through exhaustion, through the slow realization that the thing you've been avoiding might be the only thing that actually works.
A single larva, barely noticeable to the eye, can consume roughly 25 milligrams of dead tissue every day, working continuously, without fatigue, without pauses. Multiply that by dozens of larvae placed carefully into a wound, and suddenly tissue that resisted months of drugs and dressings begins to disappear within days. A typical treatment session lasts only 3 to 5 days, yet in that short window, wounds that seemed permanently infected often transform. Odor fades, black tissue retreats, and healthy red granulation slowly takes its place. Clinical outcomes consistently show striking success rates, especially in diabetic foot ulcers, pressure sores, and localized gangrene, the very conditions most likely to end in amputation. Hospitals report fewer surgical interventions, shorter hospital stays, and dramatically reduced costs compared to prolonged antibiotic therapy or repeated debridement surgeries. What makes this even harder to ignore is the economics. A therapy that costs almost nothing compared to modern medical technology ends up saving limbs that would otherwise require lifelong prosthetics, rehabilitation, and chronic care. A cheap organism, dismissed as vermin, quietly preserves something priceless: a human limb, a human life, a future that was moments away from being cut away.
Maggot therapy, for all its effectiveness, is not a universal solution. There are wounds it cannot treat, patients it cannot help, situations where introducing larvae would cause more harm than good. The limitations are specific and important, because understanding where the therapy fails is as crucial as understanding where it succeeds. Not every chronic wound is a candidate. Not every patient can tolerate it, physically or mentally, and not every clinical scenario allows for the slow biological process that maggots require. The first constraint is anatomical. Maggots work on surface tissue, on wounds where dead matter can be accessed and consumed without risk of catastrophic damage. But some wounds go deeper than that. Some expose major blood vessels, arteries and veins that sit vulnerable beneath thin layers of damaged tissue. Placing maggots into such a wound creates a danger that outweighs any potential benefit. The larvae, as they move and feed, could disturb fragile structures that are barely holding together. A clot that's keeping a patient from bleeding out could be disrupted. A vessel wall already compromised by infection or trauma could rupture under even the gentlest pressure. The risk isn't theoretical. It's real enough that protocol explicitly excludes wounds with exposed vasculature from maggot therapy, redirecting those cases towards surgical intervention, where the bleeding can be controlled and the vessels repaired or ligated before any debridement occurs. Uncontrolled bleeding presents a similar problem. Maggot therapy requires time, days for the larvae to do their work, and during that time the wound needs to remain stable. If blood is actively seeping or pooling,
If clotting factors are depleted or medications are preventing hemostasis, the wound becomes an environment where maggots can't function effectively. The larvae can drown in blood. The treatment can't proceed. More importantly, the underlying issue, the bleeding itself, needs to be addressed first. Maggots clean wounds. They don't stop hemorrhage. They don't repair damaged vessels or restore coagulation pathways. Using them in the presence of active, uncontrolled bleeding isn't just ineffective, it's a distraction from the real problem, a delay in delivering the intervention the patient actually needs. Then there's the psychological barrier, which in some cases proves insurmountable. The therapy requires a level of acceptance that not every patient can reach, no matter how desperate the medical situation. Some people simply cannot tolerate the idea of maggots on their body. The revulsion runs too deep, too primal, beyond the reach of logic or persuasion. They understand the science, they acknowledge the success rates, they know that refusal might mean amputation, might mean permanent disability or worse, but the knowledge doesn't help. The thought of larvae feeding on their flesh triggers something more fundamental than fear, a visceral rejection that no amount of clinical evidence can overcome. For these patients, forcing the therapy would be cruel, a violation of autonomy that medicine has no right to impose. The psychological trauma of enduring a treatment they find unbearable could outweigh any physical benefit, leaving them with wounds that heal, but minds that don't. This is where the conversation around maggot therapy becomes more nuanced. It's not a magic bullet. It's not a cure-all that works in every situation for every patient. It's a tool, highly effective within its specific domain, but limited by the realities of human anatomy and human psychology. The wounds it treats best are the ones that sit in a particular zone, chronic, necrotic, resistant to conventional treatment, but not so deep or so compromised that the larvae pose a danger. The patients it helps most are those who can accept the therapy, who can push past the initial disgust and trust the process. Outside those parameters, the treatment loses its utility. It becomes inappropriate, even harmful, and medicine has to look elsewhere for solutions. The humility in recognizing those limits is part of what makes maggot therapy credible. It doesn't promise miracles, it promises results in the cases where it's actually suited, and it acknowledges, frankly, where it falls short.
And remember, the greatest obstacle in maggot therapy was never the wound itself, never the infection, never the failing antibiotics or the looming risk of amputation. It was the human mind. Patients could understand the logic, hear the statistics, even see the medical necessity, yet still recoil at the idea. The thought of living larvae on their own flesh triggered something ancient and visceral: disgust, fear, loss of control. Many refused outright, choosing pain, prolonged suffering, or even the certainty of losing a limb over the psychological horror of the treatment. It didn't matter that the procedure was sterile, controlled, painless, and often life-saving. The brain doesn't calculate survival in charts and outcomes. It reacts emotionally, instinctively, irrationally. In that moment, reason collapses, and revulsion speaks louder than medicine. The irony is cruel and consistent. The body is willing to be saved, but the mind rebels. What threatens us most is not always what harms us, and what saves us is not always what we are prepared to accept. This is where medicine quietly steps out of the laboratory and into philosophy. Is a doctor justified in offering a treatment that provokes fear or disgust if it can save a limb or even a life? Does the obligation to heal outweigh the duty to protect a patient's psychological comfort? These questions have no clean answers. Modern medicine is deeply shaped by aesthetics and expectation. We trust machines, polished devices, and complex technology, yet recoil from solutions that feel primitive, even when they are safer and more effective. The irony is striking. We celebrate innovation, but often reject nature when it appears too raw,
too honest, too uncomfortable. In this space, the physician is no longer just a scientist applying protocols, but a negotiator between evidence and emotion, outcomes and dignity, survival and consent. Medicine, at its core, is not only about what works, it is about what we are willing to accept as human beings.
And remember this final paradox because it lingers long after the treatment ends. The very fly we instinctively swat away, the creature we label as filthy and useless, becomes, under the right conditions, a precision instrument of healing. Where advanced antibiotics fail, where scalpels threaten irreversible loss, this simple organism succeeds, quietly, methodically, without ego or intention. It does not judge, it does not hesitate, it does not follow trends in medicine or fashion in technology. It simply does what evolution shaped it to do. What we call dirty is often just unfamiliar, and what we call primitive may be profoundly efficient. In the end, maggot therapy forces an uncomfortable realization. Progress is not always about moving forward, but sometimes about unlearning our disgust and listening to nature when it whispers solutions we were too proud to hear.